How early can we start ARNI in acute decompensated heart failure versus whether it should be started immediately, pre-discharge, or it should be started in the fast follow-up? And what are the precautions? Here is a study, pioneer heart failure study in patients, 881 patients who were hospitalized for acute decompensated heart failure, where the ejection fraction was less than 40%. And these patients were treated with sacubitril valsartan 200 mg twice daily versus enalapril 10 mg twice daily. And the patients were stabilized. What are the criteria for stabilization? Systolic blood pressure more than 100 mm mercury in prior 6 hours. No symptomatic hypotension in last 6 hours. No increase in IV diuretics in last 6 hours. No IV vasodilatation in last 6 hours. And no IV inotropes in last 24 hours. These are the criteria to say that the patient is stable, so that ARNI 200 mg twice daily can be started, or the tolerated dose can be started. And what are the parameters to be evaluated? It is NT-proBNP, safety and tolerability, and clinical outcomes. And this study was followed up for 8 weeks, and it has been seen that there is a change in NT-proBNP, and there is reduction in cardiovascular death and hospitalization for heart failure with sacubitril valsartan as compared to enalapril. And this benefit started at 1 week and followed. It persisted up to 8 weeks. Pre-specified subgroup analysis in the pioneer heart failure study in the de novo heart failure patients. It has been seen that de novo heart failure patients already on ACE inhibitors or ARB were 7%, without ACE inhibitor or ARB were 27%, where patients with chronic heart failure with ARB were 41% and without ARB were 25%. And it is seen that the change in NT-proBNP after 8 weeks was significantly reduced with addition of ARNI in patients with de novo heart failure. But this effect is reduced if the patient were already on ACE inhibitors or ARB. So improvement in early clinical outcomes are reduced in a scenario of pre-treatment with ACE inhibitor of ARB.